everyone.
Good morning.
I welcome everyone, all the participants and the faculty to this 4th International Cardiology CME on CTO PCI Master the Complex. CTO is one procedure where we have to be very careful in assessing the angio properly. So in assessing the angio, because the procedure is expensive, the complication rates are higher. So we need to repeatedly study the angio and also repeatedly study the angio to decide the strategy. After you study the angio, the strategy for the CTO algorithm is based on 4 anatomical parameters. The ambiguous proximal cap. What do you mean by ambiguous proximal cap? It is where the cap is usually blunt. There are multiple branches there, or collaterals from the cap, and the course of the vessel down beyond the cap, proximal cap, is unclear. That is when we call it an ambiguous cap. Once ambiguous cap is there or not there, once we decide, then we should look at whether major side branch is there at the distal cap or disease at the distal target. If you don't have the disease or major side branch at the target, then we can consider going antegrade wire escalation. And if the length of the CTO is more than 20 millimeter, less than 20 millimeter, then we can go with the wire escalation from true to true lumen, sequential wire, or even we can use the cross pause, especially used in ISR and also sometime in native CTO. If the lesion length of CTO length is more than 20 millimeter, antegrade dissection is the preferred approach, and we can use cross pause and stingray. Earlier, it was star for ADR, or a contrast guided star, or mini star, or last. But these techniques have lately become less popular after the cross pause and stingray is introduced, because this gives very controlled dissection reentry, and the long-term results are also better in terms of depth, mesh rate, and TLR. Everything is better if you use cross pause. So that's why it has become popular lately. So if the major side branch at the distal cap and disease is there at the target, then we have to look for collaterals, either it's a channel collateral or a collateral of the graft. If they are suitable, then we can consider primary retrograde, straight away retrograde, without attempting the antegrade. The lesion length, if it is less than 20, then true to true entry, and then wire externalization from the recipient artery. If the cap length, if the CTO length is more than 20 millimeter, then retrograde dissection reentry is what we consider, in which it can be antegrade balloon assisted RDR, which we call a reverse cut, where balloon is done from the antegrade side into the CTO to make the reentry. Or we can use if it is retrograde RDR, then we can go cart, where balloon is expanded through the retrograde approach. So this is wire based. Or we can, if it is less than 2 to 2 lumen sequential wire that we have discussed. But if the channel is not there, collateral channel or graft is not there, then we have to consider again to go antegrade. If the proximal cap is cleared with the wire, antegrade wire escalation, and good segment for reentry is there, then you can again balloon assisted subintimal reentry, or what we call a scratch and go technique, and we can complete the procedure. If the good segment is not there, then of course the imaging role of imaging comes there. Do a IVUS and judge whether we can go through to true lumen or not, or one can do MDCT guided puncture, means multi-detector CT scanner co-registered in the cath lab. If you have that facility, then it's very useful for deciding the strategy. And one should be able to, go from one strategy, plan A to plan B to plan C seamlessly. And there are 9 commandments. Before we start, doing a CTO program, we must understand that there are 9 commandments to follow. Never consider CTO PCI ad hoc, unless you are very clear that there is a trickle of antigrade flow and there is a microchannel and the duration of the CTO is short, 3 to 6 months. You can try escalation with low tip load polymer jacketed wire. And always dual injection, means RCA right and left, both coronary injections should be done. Angio should be repeatedly evaluated in multiple orthogonal views to decide the strategy. As we discussed, there are 4 anatomic parameters which will decide the strategy, and we should be seamlessly able to travel from plan A, B to C. Now, IJ-CTO score, we all know. Apart from IJ-CTO score, will tell you whether the lesion is easy to cross, CTO is easy to cross, intermediate difficulty will be there, difficult will be there, or it will be very difficult, depending on the CTO score. The higher the CTO score, less is the chance of success, less is more complication. Apart from that, even syntax score is also very important, because syntax score, if it is high, the cumulative MACE rate over 10 years and the death rate are very high. TLR is also very high. So you must look at the syntax score when you do a IJ-CTO score. The time, contrast, and radiation efficiency during the procedure is extremely vital when you start a CTO program. And dye can be used 4 times of the GFR. But if the renal function and EF is normal, maximum dye can be used is 600 ml, maximum. The procedure time usually should be not more than 2 hours, and fluoro time maximum less than 1 hour. And toolbox, of course, we must all check according to our strategy, all the hardware is available or not. In addition, we should look at the availability of cover stand, coils, and glue if required. And when to stop, you should be very clear in your mind. And we all know that if the contrast dose is exceeded, need to stop. If fluoro time is exceeded, you need to stop. And if there is a complication, you need to stop. So these are the factors which we need to keep in mind. With this brief introduction to the CTO, I would like to invite the first speaker, Jay Khatri, my very good friend. He's a director of CTO program at Cleveland Clinic, and he will enlighten us on CTO toolbox, which, when, and why, microcatheter, wire, and all other hardware, with the role of imaging, the case-based learning. Jay, can you start? I will, of course, go off the screen.
Thank you so much, Dr. Bang, for the invitation. And happy Father's Day to everyone in the audience.
Yes.
Let me pull up my slideshow here.
Yeah, sure.
Great. So can everybody see my screen?
Absolutely.
Great. So I took some liberties. I saw some of the other topics coming up in the program. So I'm going to focus on the antegrade wire escalation aspects of the CTO algorithm and toolbox, because I think that to get beyond that would be the entire session, and I don't want to take up too much time. These are my disclosures, nothing relevant to the talk today. let's focus on antegrade wire escalation. Why is this important? This is the most broadly applied crossing strategy used in CTO PCI. Basically, any interventional cardiologist can antegrade escalate a wire through a CTO. We're all trained to do that. It doesn't require advanced knowledge of the more complicated crossing strategies. So it's the most applicable tool, and therefore it's the most widely used tool. But there's a lot of variance that we see regionally. And you see this at meetings. If you go to international meetings, you'll notice that North American operators very frequently will dichotomize CTO lesion based on the length. If it's longer than 20 millimeters, North American hybrid operators will typically advocate for a more advanced crossing strategy, be it crossbar stingray or go retrograde, whereas our colleagues in the Asia Pacific and the Euro regions tend to still favor antegrade wire escalation. And, you know, I think most of this has to do with regional availability of equipment. And specifically, I want to talk about wires because that's what we're here to talk about is equipment. Everybody knows to use a soft polymer jacketed tapered wire to try and probe at a CTO. Everybody knows that. But there are different types of wires that are available, many of which were available in the rest of the world and not available in the US, specifically Fielder XTR, Fielder XTA. These wires only became available in the US in March of 17. And this is a tapered soft polymer jacketed wire, which has been optimized to retain its tip shape and have one-to-one torque response. And this is a wire that we did not have in the US, whereas what we did have is Stingray. And that's something that many parts of the world did not have ready access to. So that sort of leads to this sort of divergence of thought in terms of how best to handle these cases. But the wire is so important that it's actually specifically highlighted in the Euro CTO and Asia Pacific CTO clubs guidelines. Enough so that when the wire became available in the US, we decided to test out this wire more academically to try to understand what this wire could do. And that's really what I want to focus this talk on. This is a paper that we just published last month. One of my fellows published this paper. What we did is once the XTR and A were available in the US, we went and dedicated the next 155 cases in our lab to antegrade wire escalation and to start with the fellow using XTA or XTR. And what we see is you can take a look at this a couple of different ways. So basically JCTO 0 to 1 lesions we're very successful at, and you would expect that because these are easy. As you get to JCTO 2 and 3, the success rate of XTA and R starts to drop to around 60%. But if we just add one more wire on top of the XTA and R, we can get up to 77%. And when we get to very difficult lesions like JCTO 4 and 5, antegrade wire escalation is not that successful. We have to use advanced crossing strategies to get to 70%. And the same can be said when we look at the hybrid algorithm. When the hybrid algorithm tells us to go antegrade, the XTA and R are 74% successful, just alone those two wires. Add any additional stiff wire, you can get up to 85%. But as the hybrid algorithm recommends ADR or retrograde, our success rates drop. So that's not surprising. These are useful predictive tools, and we can use them to determine the best way to attack a lesion. But what's very interesting is that irrespective of the lesion complexity and irrespective of what the hybrid algorithm recommends, if the XTA or R are successful, the wiring time is low. You can see down here in the bottom panel, when we cross, it's very, very quickly. So what you can take from this is with an inexperienced operator, there's very little to lose by trying with these wires. They're too soft to really do any harm. And if they're going to succeed, they succeed very, very quickly. And if they fail, you're basically set up for more advanced crossing strategies, be it ADR or retrograde. And so this has kind of changed our approach, at least in Cleveland, where we have more of an international algorithm, incorporating some of the thoughts from the Asia and European groups and incorporating that in the North American hybrid algorithm process. And I'm going to get into more of the practical highlights of this, but before we get to that, I want to point out this one slide. So from 2009 to 2013 in the US, the success rate of CTO PCI was only 59%, okay, with a 1.6% MACE rate. Now, more recently, a paper was published using the Michigan registry, which is our neighbor here. And what they show is rather disappointing. So despite all this technology, despite all these algorithms, despite all this teaching that we've had, the overall PCI volume has been very flat. It's only 4.5% of total PCI volume in Michigan. And the overall success rate still remains below 60%. And the complication rates are not that great either. They haven't dropped. So what this means is that there's room for improvement, that we need to incorporate thoughts and algorithms from our colleagues around the world to try to get better. Just sticking to the North American hybrid algorithm isn't enough. So let's get into the toolbox itself. I'm not going to spend a lot of time on microcatheter simply because I think the other speakers will have a lot more to say about this. The microcatheter is mandatory for antegrade wire escalation. You have to deliver a microcatheter to the proximal cap. That is your base of operation. Without having a microcatheter there on a workhorse wire, you really can't do a CTO. Once the tip of the microcatheter is near the proximal cap, you can exchange wires, change the shape. The microcatheter dramatically improves the torque response of the guide wires you're using, and it can dramatically improve the penetration force of the wire as it's applied at the plaque. This is really what I want to say about microcatheters. I don't think that specific vendor discussion is necessary because there's variability in terms of what's available in your region and in your lab. But basically they come in two lengths, 135 and 150. And I think that the 135 is probably better for antegrade wire escalation. Catheters can be torqueable or not torqueable. And I think that a torqueable catheter is probably better for antegrade wire escalation. And they come in low profile and high profile microcatheters. And again, I think there are pluses and minuses to this. A low profile microcatheter can get through tortuosity easily, but it loses the push that a high profile microcatheter would have to cross a lesion. So those are the things that you kind of have to measure as you choose which microcatheter to use. There's always a pro and con to all of these things. So the panel on the left shows a microcatheter that is torqueable. And what we did is we spun it so much that it actually kinked and fused to the guide wire. And once this happens, you have to remove everything. You have to remove the wire and the microcatheter and basically start all over again. And on the right, if you look on the right carefully, you can see as we're torquing the microcatheter, the tip of the microcatheter separates from the shaft. This is another problem that happens if you over torque a microcatheter, and you need to be aware of this problem occurring. We just have started experience with our Mamba microcatheter. That's from Boston Scientific. They in theory may have solved some of these problems because there's no longer a separate tip that's welded to the shaft. It's all one piece. We've only used it for about 5 or 6 months, so I don't know if I can pass judgment on that yet. But these are things that you need to be aware of as you apply microcatheters to antegrade wire escalation. This is what everybody's here to talk about, and that's the wires. And so this is the matrix that we used at Cleveland Clinic to select wires for CTO intervention. Basically, you look at penetration force. They come in three groups. There's low penetration force, intermediate penetration force, and high penetration force. And each of these wire groups have a specific role. So the soft, low penetration wires, they're used for intimal soft tissue tracking or to find microchannels. And basically, these wires are used passively. You allow the wire to find the path rather than you steering the wire to the path. The wire that we use most commonly is the Fielder XTA, but we also have used the XTR to a fair degree as well. The next category is this intermediate wire. These wires are designed to cross fibrocalcific hard plaque. And the idea here is to actively control this wire. You use this concept of deflection and rotation, and I'll show you some specific examples of that. The wire is pushed until it deflects in the plaque, and then you rotate the wire to try to tear a path through. And the wires that we use specifically for this purpose are Gaia 2nd, Gaia 3rd. I included Gladius Mongo and Gladius in here. They're not the same thing, but they're 3-gram wires, so I kept them in this category, and I'll show you exactly when and why we use those wires. And then the last category is the high penetration wires. These are used specifically for cap penetration, just to puncture a hole. Beyond that, we really don't have much of a role for these wires, and specifically the wires that we use are Confianza Pro 12 and on occasion a Stato 20. But the role here is just to make a hole and then rapidly de-escalate. So with that being said, I should just mention that the CTO wire has to be shaped. In some occasions, it comes pre-shaped like Gaia 2nd, Gaia 3rd, Gaia 1st. They come pre-shaped with a 1 millimeter bend on the tip. Other wires come straight, but typically the bend that we put on these is a 1 millimeter 45-degree angled tip. And this is ideal for trying to negotiate through the CTO. And this is not the tip that would be used to deliver a microcatheter to the proximal cap. So already you see how without the microcatheter, this would be very difficult to do. But what are some of the innovations that have changed wire technology? This is a slide from Asahi. And what they have done is they have created wires that have a composite core and dual coil technology. And basically what this means is the wire has one-to-one torque. What I do on the back end happens one-to-one on the front end. And it also causes the wire to have tremendous tip retention. And that's really important. And these are things that we didn't really have in many applications, at least not in the US until recently. The wire technology is applied to tapered wires, to stiff wires, to coiled wires, to polymer jacketed wires. It's sometimes called Sion Tech, sometimes it's called Act One, depending on the market that you're in. But basically that's what this is, this dual coil composite core technology. And it's something unique that Asahi has that I think gives their wires somewhat of an advantage. It's not without its flaws. So this is a dual coil technology wire that was torqued into a lesion, and it can break. And when the wire breaks, the inner coil separates. You see here, this inner coil is not radio opaque. You cannot see this on fluoroscopy. So if you're using this wire and you see the tip no longer responding to your input, you have broken the wire and you had to put a microcatheter up in order to try to retain all of this inner coil. Because if you try to pull, you're not going to know for sure if you removed all of this, because this is not radio opaque. So that's just a word of caution I would give you about these wires. Asahi is addressing that with another technology called X-Strand. This is also something that is not yet available in the US. Many of you in the audience may have already used this, but this is basically a coil within a coil within a coil. And the idea here is to prevent that fracturing that we saw on the slide prior. So let's get into the cases. So this is an RCA CTO with a tapered proximal cap, which you can see here. The lesion is relatively long, it's longer than 20 millimeters, and the distal cap is at a bifurcation. And there's moderate tortuosity and calcification throughout the lesion. So this is an artery that typically we would not be too enthusiastic about antegrade wire escalation, but this is part of our paper, so I'm going to show you these cases that we did for the study. So this is, on the left panel is a Fielder XTA, and you can see how it's buckling here, and this is what I tell the fellows. If you see the wire buckling, that is a deflection point where the wire is not finding a path. So you cannot really make this wire do anything once it deflects. You have to change what's happening. You can't feel what's happening. You have to just see it on a fluoroscopy. All we did is we moved the microcatheter back a little more proximally, and then we re-advanced. And you can see now the wire is not deflecting at all. It's perfectly straight. So to use XTA, XTR is completely visual. If it looks like the panel on the left, that wire is deflecting, that's not going to work. If you see what I see on the right panel where the wire is perfectly straight, no deflection, that's perfect. That wire, you can just allow it to passively slide through the lesion. And so this is a completion angiogram of that case, which was done successfully using just XTA. And then this is another case I'll share with you. So this is a case of a proximal right coronary artery where there's a lot of ambiguity at the proximal cap. There's a side branch located right at the cap. The lesion is around 20 millimeters, and there's a very good distal landing zone. So this is a case that typically in the US, we would probably be looking at doing an ADR on. But what we did in this case is we put a guide wire into the RV marginal and put an IVUS probe in there. And then you can see on the left panel, the IVUS is in the RV branch, and you can see here that we can very nicely show you the cap of the CTO. And this is where the penetration wire comes into play. So what we do is we puncture under IVUS guidance with a Confianza Pro 12, maybe 5-7 millimeters maximum. And it's safe to do this because we can see under ultrasound that we're going directly into the CTO segment. So it's perfectly safe to do this, but then we stop. Once we've achieved this, and we've confirmed under ultrasound that we're in the right space, we stop and we de-escalate. And so this is a de-escalation with XTR. And you can see again, the tip of the wire is not deflecting anywhere. It's perfectly straight. And that's what you want to see. And that's the only cue that you get with this type of wire, that the wire is traveling correctly. The minute the wire starts to deflect, it's entering a subintimal dissection plane and you need to stop. But if it's perfectly straight, you can continue on. And this case went rather smoothly, and this is a completion angiogram after we crossed and stented. This is a little bit more of a complex case. A patient that was referred to us, a young patient who ideally should have been sent for bypass surgery but declined, had to have multivessel PCI and then was coming for staged LAD CTO intervention. So you can see there's a very blunt proximal cap. The CTO itself is probably less than 20 millimeters, but there's a distal bifurcation. And I don't see a lot of calcium and tortuosity. He's a young patient, so I didn't think that this would be too hard to do. So what we did is I'm going to save you some of the details here, but what we did is we were able to get in this diagonal branch and put an IVUS probe, and then we probed the distal cap with a Fielder XTA. And you can see that the XTA is above this contrast. The contrast is below the wire. Once this happens, the wire is in the subintima. And this really cannot be corrected with a soft polymer jacketed wire, no matter what the technology. Once this wire has gotten subintimal, you have to change your tactics. And this is where we move to the next category of wire, the more intermediate wire. So this is a Gaia second. And here we're using fluoroscopy and feel. So now what we want to do is we want to feel the wire engage tissue. And when you feel the wire engage tissue and you look on fluoroscopy, what you'll see is that deflection. So right here, the wire is deflecting, and all I do is rotate. And once I rotate the wire, it tears through this fibrocalcific tissue, and then it's free. And then you can see how the wire sails down the artery once it's free. So this is a slightly different technique that, quite honestly, for me, it took some time to understand exactly what this means. But the polymer jacketed wire that we used earlier was purely by visual cues on the X-ray machine. Whereas these wires, you had to feel with your hands that the tip of the wire has engaged tissue. And then fluoroscopically, you'll see that the wire will start to deflect a little bit. As soon as it deflects, you had to apply some torque to rotate the wire. And the torque is so powerful in these wires that it will tear the tissue and create a space. And that's what happens in this indication. You'll see here the wire frees up and it just sails down the LAD. And this is something that cannot be done with a polymer jacketed wire. The polymer jacketed wire will continue to follow the path of the first polymer jacketed wire. So this is where you have to change. And this is the completion angiogram of this case. This is a pretty interesting case. It's a patient who has a proximal RCA CTO. A lot of ambiguity. You can see there are multiple branches at the proximal cap. No clear idea where to go. And also the vessel is very tortuous. It's hard to know in here where the artery is and which way the artery turns. There's multiple side branches that we had to deal with. The lesion is greater than 20 millimeters. Now there's a good landing zone distally. So normally in our old way of thinking, we would quickly get subintimal here, bring a crossbar stingray to here and try to re-enter. That's how we would do it in the past. What we did this time, we put an IVUS probe in again. So this is an IVUS probe in an RV marginal. This is the CTO cap, which you can identify. And then we safely punctured again with Confinza Pro 12. Just make a puncture. That's all we're doing here. So on the right panel, nothing more than a puncture under IVUS guidance. And then we de-escalate. So we de-escalated with XTA, XTR. We could not get true lumen. And then when we can't get true lumen with those wires, we tried Gaia. Again, got subintimal. And so when none of these wires work, we like to use a wire called Gladius Mongo. Now, this is a wire that Asahi developed actually for the American market. So we got this wire first. I'm not sure about its availability in the rest of the world. But this wire is 3 grams, polymer jacketed, non-tapered, and it's designed to prolapse. Its purpose is to prolapse and get subintimal. So we use this wire to set up a stingray. But what's really interesting about this wire is very frequently as the wire prolapses, it will create a star. And we see this very frequently. So the intention here was to get subintimal to place a stingray balloon. But what happened instead is the wire starred into the true lumen. And it starred into a very opportune position. We didn't lose any side branches and went ahead and stented this vessel. And we've seen this time and time again with this wire, and it's pretty exciting. This is another case, an RCA that we did about 3 weeks ago. You can see the Gaia is deflecting to the left. You can see the lumen is to the right. And we cannot correct. We tried XTA-R, Gaias. We could not get the deflection to be corrected. So then again, we're trying to get subintimal. So the middle panel, we're trying to get subintimal. So you can see that the prolapse wire is to the right, like what we wanted. And then if you look on the very right panel, again, the wire simply starred into the true lumen. And we were able to complete the case without even having to do Stingray because the way that the wire prolapsed. And the last thing that I want to show you is a wire called Gladius. Now, this is a wire that's very similar to Gladius Mongo, except it's not designed to prolapse. Again, 3 grams, non-tapered, polymer jacketed. And this wire was actually marketed, at least in the United States, for peripheral intervention, but we use it in the coronaries for this purpose exactly. This is an RCA CTO that we crossed, Antegrade, and there was a very, very angulated PLV marginal that we could not wire. So after we crossed, there was no way to make this turn. So we put a hairpin wire in, and the way that we put the hairpin wire in is we use a dual lumen microcatheter to deliver this hairpin wire, and then we just pull back and then select out the branch that we can't wire. We've done this with soft wires, Xi'an Black, Fielder FC. The biggest problem that we have with all these wires is that once we select out the branch, we can no longer put in a microcatheter. Anytime we advance the microcatheter, it tends to prolapse and go down the PDA instead of in the PLV. The Gladius wire seems to have the perfect properties. It's very steerable and also very supportive. It allows us to do the hairpin technique and also to deliver microcatheters with no difficulty. And so this is just a little niche role for this wire, and I want to include it because we've had great success with this for this particular application. So that kind of concludes my talk. I just wanted to highlight some of the main points. Purpose-built soft guide wires in conjunction with a microcatheter can achieve very high antegrade wire escalation success in low complexity lesions and with very low complication rates. This may be the ideal strategy for less experienced operators. And in cases that are unsuccessful, it prepares the lesion for more advanced crossing strategies, be it ADR or retrograde. And antegrade wire escalation can be improved with intravascular ultrasound and the judicious application of stiff guide wires for puncturing or prolapsing guide wires like I showed today. And we can maintain procedural efficiency with antegrade wire escalation as our first crossing strategy, irrespective of lesion complexity. You saw that from the paper that we published. So that's sort of our journey. We are now in sort of an international mode rather than a North American mode or Asia Pacific mode or a Euro mode. And hopefully you'll have found some of the cases that we showed here to be useful for your practice.
Are you done?
Yes.
Yeah, okay. Thank you very much. Brilliant talk. And we will have a discussion at the end, question, answer, and discussion at the end. So please stay on. May I invite the next speaker now? Dr. Omar. Is he there? Dr. Omar? Dr. Omar, is he there?
Not yet.
Not yet. Okay, then let me invite the third speaker, Dr. Arun Kalyan Sundaram. He is the Chief Division of Cardiology, ProMed Hospital, Chennai. But he's also a owner of this hospital and very well trained in America. And he's expert in ADR, that is cross-cross Stingray technique, and that he will express us the details of step-by-step ADR, how to use Stingray and cross-pass. Arun?
Can you guys hear me?
Yes, of course.
Okay, good. So, hey, thank you so much, Dr. Bang, for having invited me for this symposium. And Jay, fantastic talk, really enjoyed it. And, I miss being at Cleveland Clinic. So anyways, just want to kind of go over antegrade dissection reentry with cross-pass Stingray. And I'll try to stick to the 15 minutes that I got. So I'm going to talk about the basics of ADR and kind of show you a couple of cases. and hopefully it kind of demystifies some of the stuff about the whole crossbar stingray stuff. It hasn't had much penetration in the APAC region, and I think cost has been cited as a big factor, and also the fact that people are so used to wiring, so sometimes there's an inherent bias to not switch strategies pretty fast. Now, the first and the most important thing that I want to tell you is that just because you can do crossbar stingray or you can do retrogrades does not mean you forget your wiring skills. And I think this is really a key point that I wish to emphasize. So you can't take an average or a mediocre operator and make him a CTO expert just because you got stingray or you know how to use a microcatheter. So I'm going to actually start off with a case. This was the case in India, and I mean it's a different world out here. I'm going to start off with that. Actually, this is from Ramesh's state. So it's from the previous Andhra Pradesh. So as you guys can see, post cabbage, the graft to the circumflex is patent, and the LAD lima is gone. And you can kind of see that it's a very longish lesion, and you can kind of see the distal part of the LAD. And so there you are. So my initial plan again was, maybe I shouldn't try wiring this. I'm going to go ADR. If it doesn't work, there was one high-end collateral through the graft into the circ territory and then through an epicardial into the distal LAD. So that was kind of the plan. So I started off, here I am, you can see the microcatheter, and wiring just didn't work. So I'm not going to waste a whole lot of time. But once the penetration was done, I think one of the key things that you should take away from Dr. Jay's talk is that don't waste a lot of time with very, very stiff penetration wires. If these don't travel long distances, because these will go. And if you trust the tactile feel, you might end up in a place where you don't want to be. So once the initial penetration was done, this is a knuckle being made, and memory serves right, this was a Fielder XT. The wires that we use typically to knuckle are XT, XTA, XTR here, and pilots. Any wire can be knuckled. And once we get Mongo, I think it'll have a lot more. It's a wire designed for penetration. I mean, I'm sorry, for knuckling, as Dr. Jay had just said. So hopefully that'll kind of help change the game a little bit. You also have the fighter wires from Boston that can knuckle pretty easy. So once the knuckle was done, right? I mean, you can see that my plan is to do ADR, and I'm following the knuckle with a microcatheter. That's the microcatheter. I think you can see the pointer here. That's microcatheter knuckle. Trying to wire this is super hard just because it's long. Tortuosity, I don't know the course of the vessel. So here it is going. I got a big knuckle. I'm all set. I'm going to go get my stingray balloon down and re-enter. So, however, things didn't go as per plan. I'm pretty close to where I want to re-enter, and then I find out, which can happen, I think, in a lot of third world countries, and I think most of the audience is in India. So many times you don't have balloons available. So there is no stingray balloon, and I was told that there is, and it's not there. So what's the plan now? So do we persist with antigrade? Do we switch to retrograde? What do we do? So I ended up actually doing parallel wire, which, I mean, to be honest with you, 4 years ago, I'd done parallel wires, but that wouldn't have been my default strategy. So had a dual lumen catheter, and then again, with injections, I kind of figured out where the vessel itself was, and that's a Conquest Pro 12. I'm just wiring this, and I'm in the true lumen, exchange for with the microcatheter for a workhorse wire. And essentially, this is the final result. So the point of showing this case is that while you might be really good with ADR, you still have to know how to wire, how to do retrogrades, etc. So, but why does ADR matter? Why do we say it's important? Because long lesions, as I think Jay had just said, cannot be consistently wired even by expert operators. And some cases have no retrograde options. I'll kind of show you a few cases of this. And sometimes even when you have an option, you can't wire it. So the theoretical construct is that when you have an ambiguous course or a very tortuous vessel, a stiff wire tends to go straight. It's just the physics of it. So when you have a knuckle, these tend to follow the natural course of the vessel. And once you get to the distal cap, you have ways to re-enter. And this is the famous, the original hybrid, version 1.0. And again, typically, if you can't wire it successfully, have a plan for dissection reentry antigrade. And I'm just going to go over the steps here. I think already between Dr. Bang and Jay, we've kind of covered about when do we consider ADR. I mean, you got to know where to go. So you have to have an unambiguous cap. And then let me just show you how we go through the steps. Get the crossbars to the proximal cap. All right. And then this is what you typically do. You want to have 2 to 3 finger breadths and have the crossbars here. This is just a blunt dissection tool. So if you have a blunt cap, crossbars is not going to work, but you got to spin this really fast. Unlike Tornus or other microcatheters, you spin really, really fast. And remember again, it only works if you have a tapered cap, not if you have a blunt cap, because a crossbars itself has a blunt tip. It's a 1 millimeter blunt tip. So essentially it's a control knuckle. So if you have a blunt cap, you want to penetrate with a microcatheter and a penetration wire, get a knuckle going, and then switch to a crossbars. And again, you got to see where the crossbars goes, because it goes where it wants to go. And typically it tends to follow straight lines once again. So you might get into branches, especially in the RCA. In the LAD, you might end up getting into a diagonal. So you need to assess periodically in orthogonal views to make sure you're where you intend to be. Just as a side point, once you get into the subintimal space, remove the antegrade syringe so that inadvertently you don't inject, because that is a recipe for disaster. You just create a huge subintimal space, which will make your reentry extremely challenging. Now, you can dissect with the boss or with a knuckle. Either works. The only advantage of using a crossbars is that it forms a more controlled knuckle than with a wire-based knuckle. And again, Mongo, I think, will kind of change the playing field a little bit. Jay, we don't have this in India. I've used it once or twice in the US, but for most of the operators, I think still boss is a good way to go if you have a big knuckle. And I'll kind of touch upon some of the things that we have changed over the last several years since the inception of ADR in 2011. So once you are at the landing zone, which is beyond the distal cap, what you're really doing is now exchanging the crossbars for the Stingray balloon catheter. The Stingray balloon catheter is just a controlled way of achieving reentry where you intend to achieve reentry. And the Stingray balloon, as the name itself suggests, is a balloon shaped like a stingray. So you guys can kind of see it here. It's got 3 holes, and 2 of these, the proximal and the mid, are 180 degrees opposite each other. So one will point you towards the true lumen, and the other, outside through the adventitia. So once you get your Stingray balloon to position, you want to move your II so that you get the optimal view. The one on the right is wrong because you don't know if you want to take the proximal hole or the mid hole. You want a position like what I'm showing you right now, because this way you know that the vessel is above the Stingray balloon catheter. How do you know where the vessel is? By a retrograde injection. You do not want to inject antigrade. And once you know this, you traditionally, and in fact, in most cases, what we do is make a stick with a Stingray wire, and I'll kind of show you some of the other wires that we use to do a stick. And then you swap it out for, typically we used to use a Pilot 200 for this. There have been other wires that have been used for the swap. What's the rationale? When you have a diseased vessel, you don't want to take a Stingray or a Conquest Pro 12 or a Confianza Pro 12, as it's known in the US, to take it through a very diseased vessel. What you want to do is make the stick, take out the penetration wire, and then take a hydrophilic polymer jacketed wire, often the Pilot 200, to find the same hole and get into the distal vessel. Get the Stingray out, put in the polymer jacketed wire, and do it. What has changed in the last couple of years? One, we used to use mostly 8 French femoral in the US when we started off in 2011. I've mostly been in the APAC region. There's a big hesitation to use 8 French guides. So many times it's 7 or even 6 French guides that we use these days. Trapliner is not available in most of Asia. So, however, ADR contemporary can be done with a 6 French, or ideally at least a 7 French guide. We used to always start off with a cross boss. These days, you finish with the boss, and many times you don't use boss all the time. We used to say, hey, anytime you have a knuckle, you got to use a boss. Not anymore. You have the Stingray balloon catheter. These days, you have the Stingray LP, which is a low profile one, so which is compatible with 6 French. The reentry wire just used to be Stingray. Now you can use a Stato or Conquest 820, Hornet 14, which is available now. That's from Boston. You can use the Gaia 3 or the Gaia 3 Next, or you can use the Stingray wire. And we used to do a stick and go, and then we moved on to stick and swap. And now there are cases where you still go back to stick and drive. And straw or hematoma management was only if we lost visualization. If you have trap liner, or if you have a balloon that you can kind of inflate up front, managing hematoma is the single most important thing in ADR. And we want to we want to be preemptively thinking about how do you manage hematoma. And initially it was kind of a free-for-all. We didn't really know what to do when you ran into trouble. Now we have clear guidelines about like, what do you do if you're going to run into a problem here or there, et cetera, et cetera. And we do have good data on ADR, thanks to actually the colleagues in the UK. You have pretty good long-term results, at least I should say intermediate term results with subintimal stenting. And initially we used to just go to the easiest area for reentry. These days, most of the operators who are comfortable with ADR really want to re-enter right after the distal cap, even if it's a disease zone, because we have gotten pretty good over the years. And the 20 millimeter, which was the initial concept, is no longer set in stone. The key concept is if you can't wire it efficiently, think about ADR if you do have a landing zone. And even in the APCT algorithm and some of the other regional algorithms, I think ADR is kind of here to stay for the time being, at least. So I'm going to take the last couple of minutes to just show you a couple of cases. I think I'm running a little short of time. I got about 3 or 4 more minutes. So I'm just going to skip this first case because it's not as cool. And also it's a little older case. So I'm just going to keep going here. All right. This was guys, can you hear me still? Yeah.
Arun, yeah, we can hear you. Arun, time is no problem. You can take 3-4 minutes more. We can reduce the discussion.
Sure. So I'm going to really show this case because this was a fantastic case that I did last year along with a Japanese CTO expert. And I kind of want to just touch upon this because this really shows you the best of East and West, and also what works, what doesn't work, how do you keep moving. So as you guys can see, this is a case of a circumflex CTO that I had the opportunity to work with one of the Japanese senseis to do along with him. So we had like 2 experts. This was an IJ CTO. This was actually for a live case. And you guys can see it here. There's nothing from the right side in case anyone's wondering why you don't have a second guide, which is really a key thing, as Dr. Bang had said. There's an ambiguous cap. So we've kind of looked at the pictures here, right? Longish lesion and distal vessels possibly okay. There's somewhat of a bifurcation. Collaterals, initially we were unsure, and during the case we realized there were no collaterals, and the proximal cap is ambiguous. So the plan was to start off with antegrade wire escalation with after you ascertained where the proximal cap of the IVUS. And I think Jay has shown a couple of cases beautifully of IVUS guided entry. Now, again, remember, if you're going to be a CTO guy, you need to be comfortable with all these different modalities. And then if this didn't work, our plan B was to go attempt retrograde. And if that didn't work, then depending on who was primary, to either try parallel wire or ADR. And so here there was a branch, a high OM there, was kind of a smallish branch. We wired it, got an IVUS catheter, and then we were able to penetrate the proximal cap successfully, identify it and penetrate it. So what we had to do, because this is a 7 French one and we couldn't do a live IVUS guided puncture, We identified it, took out the IVUS catheter, put in a dual lumen catheter. There was a Crusade, and then penetrated successfully with the UB3, which is again, I don't know if UB3 is available much in the US, but it's available in Asia. So it was successfully penetrated. However, then we started running into trouble. Now, so, we're trying to wire this for a while, and lo and behold, we were nowhere close to the circumflex. In fact, I was not even sure we were in the architecture of the vessel. And, again, we have two experts here. The Japanese operator was the first operator. So, and he was an invited guest. So we were trying to see, okay, what else would you want to do? So a long time has passed. We've been trying to wire antigrade, and there was no antigrade option. And at this point, wire escalation is clearly failing. And then we explored some collaterals. There really was no retrograde option. So as you can see, here's the wire. We were nowhere close to the circumflex. And the problem was, with all these attempts, we were losing visualization. So already the distal landing zone was not great, and now it's getting worse. So I'm going to show you this quick thing about why knuckles are fairly safe. This is something from Bill Lombardi. And what I want to show you is that penetrative wires really can go bad. So when you take a stiff wire, and this is a model that Bill had done with a 3D printer, and that's a microcatheter, your stiff wire, and boom, it just pops right out. Okay. And so once you're in the subintimal space, knuckles tend to stay within the architecture of the vessel, and that's all that we really care about. We don't want to create a perf. As you can see, you can cross it fairly safely. So, anyways, after a while, he kind of agreed to knuckle, and so at this point, we're already like 2.5 hours into the case. That's the knuckle going. And once I got the knuckle going, I knew I was in the architecture of the vessel. In fact, this was just I'm going to go back for a second. In fact, this was just a caravel. And again, this is India. This was done at a government institution in North India. And there was no way, again, the patient has to pay out of pocket. So increasingly, I've stopped using crossbars just because it's more expensive. And here, I kind of got the caravel down, put in a Miracle 12, and that's the Stingray balloon. The two dots that you see here is the Stingray balloon catheter that's being advanced over the Miracle wire. And we knew from the initial angiograms as to how far to kind of go. And that's the Stingray balloon catheter position. I had to take a picture just to be sure I wasn't way beyond the distal landing zone, and I wasn't. Now, the problem was I had no idea where the vessel itself was. And so this is what this was, we had done some straw through the microcatheter and through the Stingray balloon itself, but it still wasn't, wasn't really helpful. And again, this is where the experience part comes in. So 30 minutes after we decided to knuckle, this ended up being a stick and drive. So this is the proximal port through which the Conquest Pro 12 wire was in. I pretty much knew I was in the vessel of where I wanted to be. Now, the one catch is that I still want to be sure that I don't lose the other diffuse marginal branch. So once I got this in, this is the same caravel being advanced over the CP12, and then you want to exchange this wire for a workhorse wire, and then put in a dual lumen catheter, and then wire the other branch. So now this was done with the same dual lumen catheter that we'd used initially to penetrate. And then this is IVUS, which shows that, you can see the other branch, true lumen. This is still true lumen. So we re-entered before the circumflex had given off that major OM. And then you can see that some of it is subintimal, clearly, which we knew. And then proximally, it was true lumen. So in the interest of time, I'm just going to skip to this. So this is just plaque and true lumen. So once you confirm this post-stent, you're good. And that was the end of the case. So the key lessons from this particular case was you want to switch to ADR early, not spend 2 hours trying to wire it. So it was definitely harder because of the hematoma and lack of visualization. Not every lesion can be wired or done retrograde or antigrade wiring for that matter. And even at the hands of experts, not every case can be wired antigrade. And knuckling is often useful in CTO PCI. And again, this is just APCTO, which shows that it is an important component. ADR is an important component of even the Asia Pacific algorithms. So in conclusion, ADR is an important technique. Have a plan. And sometimes things don't go according to plan and you got to change it. It can be done as ADR can be done as a primary strategy or a secondary strategy after wire escalation has failed or retrograde has failed. And the sooner you switch, the better it is. And my last slide, I just want to tell you that we are racing there's a charity program on July 9th, where 13 operators are going to be doing CTOs globally. It's kind of the longest CTO marathon, starting from Japan and ending in the US. So for those of you that are interested in just logging in, please feel free to log in. And it's going to be a fun fest. Thank you very much.
Sorry, thank you very much. Sorry. Thank you very much, Arun. Your excellent, brilliant talks. Appreciated. Your examples are brilliant. You showed step by step how to use stingray crossbows and various situation by case examples. So a very good talk. Please stay on. We have a discussion at the end. May I call the next speaker, as Dr. Omar is still not joined. So he's in an emergency at the moment. And I invite the last speaker, Dr. Dagupati. He will talk to us on the CTO PCI trial. What do these say?
Thank you, Dr. Bang, and excellent presentations both by Jay and Arun. And I just actually was on the call with Dr. Ömer Göktekin from Istanbul. He'll be joining in maybe a few minutes. So let me just do my talk, and then we'll have his talk following mine. And let me share my screen. So I should have probably talked, hold on. Maybe I should have talked first, I think, because what I'm going to say is mostly about the clinical trials, and there are no beautiful videos of successful CTOs and as such. So CTO PCI trials, what do they or these say to us? You know, the balance is always a problem of evidence versus clinical practice. And you know, if you listen to the CTO experts, you might say every CTO should be opened up, and if non-CTO operators might say that you're doing unnecessary procedures to technical complexity, risking the patient's costly and demanding use of resources, and it's taking longer hours, and we don't have enough labs. How do we overcome that? But the whole idea of doing CTO is to improve engine and LV function, probably. Improving survival is something like a thought, and we'll look at that, myocardial viability, and looking at the people who would benefit by favorable anatomical coronary factors. So the single largest registries from BCIS and overall mortality and CTO success in people who had successful CTO in more than one vessel, their survival was much better. And as you can see here, that of at least one CTO was associated with improved survival with a hazard ratio of 0.72, and this is for a follow-up up to 4 years. So if you compare the STEMI registry in people who had come in with STEMI and then there was a CTO, usually the mortality with even CTO coexisting with STEMI have the highest mortality, about 24%. And some people with multi-vessel disease without a CTO, they have lowest mortality. And so the burden of a CTO, even in STEMI patients, is much higher than actually having just a single vessel disease and a STEMI. So the overall mortality and CTO success, if you see in people who had a successful CTO PCI more than one vessel, on the bottom line is the number of people who are having CTOs successfully opened up is going up, increasing. And but the mortality at open CTO trial is at 6 months is 2.8%. That's in the beginning, but in the decision CTO 1 year mortality is less than 1%, and then the Euro CTO mortality is less than 0.5%. So it actually goes to saying that we have a benefit, and we know now how to reduce mortality from high-risk CTO PCI. There will be no randomized control trial that will show a mortality benefit for CTO PCI, and I'll tell you why later. In randomized clinical trials, only less symptomatic patients are included if the alternative is the optimal medical therapy versus PCI. And mortality improvement cannot be the primary goal of a therapy in a stable angina, but it should be improvement of quality of life, and which is a valid goal of medical therapy. That's what we try to do in most of the places, is to improve quality of life. There have been 4 great randomized control trials, several registries prior to this, but if you look at it, I think we'll talk more about Euro CTO and decision CTO in a bit. And Explore trial results was people who had a STEMI and then had at least one CTO, and there's opening up the CTO versus no CTO PCI. In the red, there has not been any difference in ejection fraction and or end diastolic volumes. That's what they looked at in the Explore results. You can still see my slides. Can you still see my slides?
Yeah, you can see, we can see your slide. Only thing, yeah, that's good.
Yeah. So in the REVAS trial, which is optimal medical therapy versus PCI as well, there has not been a great improvement in the segmental wall motion abnormalities or segmental wall thickening by MRI and at 6 months follow-up. So there has not been in the MRI study, which is really good. We thought that it was going to be, it was negative. So then I said, we'll talk about Euro CTO and decision CTO in greater depth. So when should CTO be opened up? I think this is a nice paper from Manos Brilakis. You have to weigh the risk and the benefits, as we said. What are the ultimate goal is to improve angina, exercise capacity, and quality of life. You should look at the likelihood of success and lesions and length and quality of the distal vessel and how are the collateral vessels as well. And the operators, the more we do, the better we get at them. And we talk about a lot of things at this webinar and maybe multiple other meetings. You need to really be an expert in all of them. It is going to be not easy, and you need to be dedicating yourself to one or the other. You can't just say that I'll do everything possible in the cath lab and also be a CTO expert. You need to make sure that you dedicate enough time. So, and the risks as well are emergency bypass surgery, peri-procedural MI, tamponade, which is, I think, is the most common one, and renal failure. As we said, Dr. Bank said that in people with normal renal, normal kidney function, maximum dose of contrast could be 600. And I think maybe we should try to reduce that as much as possible because something we don't like is to inject multiple times. And my last CTO for RCA, actually, with a guy who had a kidney injury was about 35 ml. And I think, so we need to be cautious in how we use contrast, and we should consider contrast as a poison for these patients. And very rarely stroke can be also seen. And ultimately chronic stent thrombosis, instant restenosis, and radiation skin injury for prolonged dose, I think. But this mostly now we are paying attention to it, and their newer systems can go to lower frame rates, and even my diagnostics, I keep just trying to tell them to go to 7.5 frames and 15 frames per second. And obviously time is the most important one in that. So let's talk about decision CTO. 834 patients were enrolled. It was actually meant to be enrolling nearly, I think, 1,200 patients, and 398 were allocated to optimal medical therapy, 417 to PCI. And so it should have been 600 each, but this is a slow enrollment, and the trial has been stopped early because of low enrollment. But 1 year follow-up is about 98%, and the 5 year follow-up up to above 80%. So the primary endpoint, which was death, MI, stroke, and any repeat revascularization, was no difference between optimal medical therapy and PCI. I mean, this trial, as you know, it is done by Cardiovascular Research Foundation, Dr. S.J. Park from Seoul. And so you have to think that all of these operators are really excellent operators. And still, if you look at it in one way, it is probably a negative trial. What happened here was that the revascularization for all significant non-CTO lesions within a vessel diameter of 2.5 millimeters or above for patients with multi-vessel disease was recommended. So the randomization happened first, and then if the patient had other lesions in other vessels, they have to be dealt with first and then go ahead with the CTO PCI. So patients were given excellent medical therapy, and including aspirin, P2Y12 receptor inhibitors, more than 12 months in case of a PCI, beta blockers, calcium channel blockers, nitrates, ACE or ARBs, and the statins. Blood pressure and diabetic control, smoking cessation, weight control, regular exercise were recommended. All non-CTO lesions should be treated. In fact, 70% of the PCI was performed in optimal medical therapy group, which is not really, if you think about it, it's not really optimal medical therapy. And multi-vessel disease was seen in about 73% in both arms, or optimal medical therapy versus PCI. And you look at it, number of total stents used was also slightly higher in the PCI, but nearly average 2 stents were used in the optimal medical therapy. And the total stent length is slightly different, but still about 53 millimeters in optimal medical therapy as well. So if you look at the CTO PCI success was high in this clinical study, and the retrograde approach lesion low penetration force wire was used in about 28%, and intermediate to high penetration was in 72%. Single wire was in 73%. We talked about actually how IVUS guided wiring is needed, but it was used only in 17%, even in Seoul. So I don't think that they have any shortage of IVUS. And look at it that, I'm sorry, this is not exactly the way it should be, but IVUS guided wiring was used in 17%. CART technique, and when I talk about these, when we say that we should become experts in this, even in a clinical randomized trial where all excellent operators are using it, CART technique is only used in 6%. So I think you really have to be excellent in these. And microcatheters are used in at least about 55% of the patients, and over the wire balloons was actually in shorter amount in 1.4%. So this is a trial that really did not address the benefit of CTO PCI versus optimal medical therapy, because CTO patients were randomized prior to treatment of other vessels. But the only pro for this is CTO PCI it did not do any harm, and there was an excellent success rate of up to 90% in these patients. And the con against this trial is a problematic study design. You cannot discriminate the influence of CTO or non-CTO PCI. and long inclusion periods and not reaching target enrollment, I think are the ones that we have to question that study. And so then is a Euro CTO. It is presented by Gerald Werner at the Euro PCR in 2017. I'll show you both 1 year and 3 year results. And it's a randomized multi-center trial to evaluate the utilization of revascularization or optimal medical therapy for the treatment of CTOs. So what they did was another similar 1,200 patients were planned to be enrolled to achieve a 90% power for the safety endpoint. Actually, the power for decision CTO after the trial was stopped was only 64% power. So you can't really make a judgment. You started off with a 90% power and then you end up with 64%. Then you have to really think, is that true comparison and whether we can take it as a mantra, so you have to think about that. So please be aware of whenever you analyze clinical studies, you need to think about what was the targeted power and where they ended up. When the power is not achieved, all those statistics go into the garbage, in my opinion. So here is a 90% power and the follow-up for 36 months. 600 patients were calculated as required for the primary efficacy endpoint. And the study inclusion started in 2012 and was completed but it was extended to 2015. But the intended patient number to assess the primary endpoint was not reached again. And the study concluded enrollment with 407 patients. So this is, again, one more sad part is that enrollment in the clinical trial should be really encouraged by all cardiologists and scientists. And that's where we unfortunately can't do it. Can't come to a consensus on these trials unless we put a lot of effort into these clinical trials. Here is a flow chart of multi-vessel disease CTOs. You actually go ahead and treat non-occlusive disease by PCI. That was done in 29% of the patients. And then if they have angina and only single vessel disease CTO, there are only about 48% of them. So we'll come to the inclusion-exclusion criteria. Patients with stable CAD and at least one CTO have to be documented by history that more than 3 months duration and a TIMI zero flow with symptoms and or ischemia and viability. So all the vessels have to be more than 2.5, AHA classification 1, 2, 3, or up to 11. The patients with multi-vessel disease should receive PCI to significant non-CTO lesions before randomization, which is a major difference between decision CTO and the Euro CTO study is that all the non-CTO PCI was done before and then they were randomized. Randomization is again 2:1. And every 2 patients that were enrolled into PCI, 1 patient enrolled into optimal medical therapy. And if the CTO PCI is success, that's good. Repeat the exercise tolerance test and objective assessment of ischemia at 12 months and 36 months. If they failed, consider medical therapy or bypass surgery. And in optimal medical therapy, if they fail, they go undergo PCI, and that number was 7.3%. Whereas in decision CTO PCI, the crossover was actually up to 20%. Optimal medical therapy included aspirin, statin, ACE inhibitors, and at least 2 anti-anginal medications. So what you can see here is that compared to baseline and follow-up, the physical limitation, anginal frequency, quality of life, all of them have increased with in the red is PCI arm. So everything is much better, and the size of the difference is seen in the length of the arrows here. So greater improvement is seen with PCI as compared to optimal medical therapy in every single agent except anginal stability. And treatment satisfaction, as we see, that is not really significant. More patients were free of angina and had better quality of life and improved physical capacity with the PCI rather than optimal medical therapy. And higher baseline scores and less symptoms in randomized clinical trials versus registry data is seen. In an open CTO registry, you see that there is the baseline here is much lower as compared to in the baseline actually with medical therapy or PCI is in nearly 75% in Euro CTO scores and as well as in the decision CTOs. So the primary endpoint in the Euro-CTO trial at 36 months is a cardiovascular death and non-fatal MI. I'm sorry, I don't know why it happened, but there's no difference between the two. And the safety endpoints, the cardiovascular death at 36 months in PCI arm is 0.42 and non-fatal MI is 0.52. So it is definitely safe to do a PCI. And here is again the numbers that at major adverse cardiovascular and cerebrovascular events at 36 months. As you see, the only thing that actually any adverse event is slightly higher with the PCI, but death non-fatal MI was not different. And sorry, ischemia-driven revascularization was much higher in the optimal medical therapy arm. So when we talk about how to approach, I don't think this is the time that you want to say that I can do all CTOs with the radial, bilateral radial, even though I have done it. And we also showcased a live case for from Turkey with Omer with the transradial PCI for CTOs. But this is not the main idea. The main idea is to revascularize successfully in 86% of the patients. And the retrograde approach is seen done in the Euro CTO trial in only 35% of the patients. And there, most of the time, they use 91% was biometric stents and more than 3 millimeter stents. Sorry. The procedure duration is 118 minutes and fluoroscopy time was 48 minutes. So see how we can limit the amount of fluoroscopy in these patients, you know. So I think with the increased numbers, obviously we can do much better job. This is from Raj Sachdeva's trial that where he looked at essentially FFR. We think collaterals, you know, well-developed collaterals versus poorly developed collaterals. The FFR is really going to be hugely different. Unfortunately, that is not true. So this is only in small number of trials. It doesn't matter whether it is well-developed or not well-developed collaterals. The CTO vessel is causing ischemia. So that's the big bottom line of this study is this paper is that anytime you see a CTO, please don't think that it is not ischemic because the collaterals are so well-developed and it is still ischemic. Ejection fraction improvement is unfortunately cannot be done, and these are the smaller clinical studies that have shown that by a successful CTO PCI, still EF has not improved. So there's meta-analysis of successful versus failed CTO PCI. The all-cause mortality is, as I want to show you, that it's less than 1%, and several studies have seen before and after 2008 is still less than 0.4. Major adverse cardiac events are also less than 1%. So in fact, the need for emergency bypass surgery is no different than other in non-CTO PCI. So I think please do not get scared about patients needing CTO PCI. We are not really causing a lot of risk. I don't know why this slide is not here, but can we expect the study to test mortality for CTO PCI? And that's what I was trying to say earlier in the beginning, that we would need at least 3,000 patients enrolled over more than 3 years to test survival. And you know, mortality in open CTO, as I said, at 2.8% at 6 months, and decision CTO and Euro CTO is less than 0.5. Euro CTO was 0.5%, decision was less than 1%. So the main idea is to impact the ischemic burden before the CTO PCI, and definitely I think this can be achieved in people who have more ischemic burden. So select anybody with more than 13% ischemia, and I think or a 12% ischemia, similar to COURAGE trial, you can make an improvement in their quality of life to show that PCI CTO is important. Should all CTOs be open? And lastly, I'll end with this. You can calculate in a progress CTO calculator. The risk of the benefit of a CTO is always given in people who have higher symptoms, but you can assess the risk based on the progress CTO score as well as JCTO and see who will benefit in the longer. So at the end, the balance of evidence after these clinical studies, I hope I could convince you that we do CTO PCI, not just because we want to do them, but it is to improve angina and improve quality of life And though we were not able to show survival or LV function improvement on myocardial viability improvement, but for the patient, what matters is the quality of life. I end here. Thank you very much for giving me this opportunity to Dr. Bang and India ACT, and also thank all the other panelists and speakers. Thank you very much.
Thank you very much, Dr. Ramesh Dagubeti. It was excellent presentation of the data. And we always have this question of, especially in stable ischemic heart disease, CTO to do or not to do, and also in ACS, but we'll discuss that at the end in the discussion. Let me invite Dr. Omar Göktekin. I'm glad you could make it.
Thank you.
And we are looking forward to your presentation. Dr. Göktekin is from Turkey, Istanbul. He is the Dean and Professor of Cardiology at Vakıf University. And he's also a founder of MENA CTO Club. And he'll enlighten us on retrograde CTO PCI step by step.
Okay. So thank you very much. Yeah, thank you very much, Vijay, for inviting me. And also I'd like to thank Ramesh, a very good friend of mine, for having invitation to this very nice CTO expert meeting, actually. So I will talk about retrograde tips and tricks. And, you know, when you say retrograde, I think the most important part is retrograde is, I think, crossing the collaterals, you know, and also inserting the microcatheter at the distal of the CTO. Once you did that, have you seen my slides now?
Yeah, of course.
Okay, all right. Okay, thank you very much. Yeah. So once you are in the distal of the CTO, the other tips and tricks more or less the same for Antegrade approach. Yes, you have to wire the CTO, and you may do mostly, if you need it, you may do reverse card. Anyway, in my practice, mostly I follow Asia Pacific CTO club algorithm. In this algorithm, if the patient has proximal cap ambiguity, and if you don't have IVOS, or if it's not suitable for IVOS, you can go directly retrograde approach to save time. Or if you have poor quality distal vessel or bifurcation at the distal cap, this is also a very good indication for retrograde approach for directly. Of course, if you have antegrade failed attention, either in that session or the previous one, you can go directly retrograde approach in that time. So when you talk about retrograde approach, we basically four technique for that. The first is kissing wire cross. If we send antegrade wire, with retrograde wire, we try to kiss both wires. So we use antegrade wire as a marker, and with help for antegrade wire, we may able to cross from the retrograde, and if we can go retrograde wire cross by itself, not using either card or reverse card technique. Card technique means that we do dilatation through retrograde wire. We don't do this anymore. Most of the time, but sometimes we can do, of course, if we have to, but most of the time we do reverse card technique, which is antegrade ballooning with the antegrade wire, and we will have we have a space here, and we try to enter this space done by antegrade ballooning with the wire. This is reverse card technique. So when you talk about the retrograde approach, I think the most important step is collateral evaluation. So we have to spend time for that. We shouldn't be hurry on this. We have to see connections. We have to see we have to look the size of the collateral. We should look carefully how much tortuosity we have. In sometimes, you know, for epicardial collateral, we might have lots of tortuosity, and sometimes we could fail to cross them. We should look exit from the donor artery or entry to recipient artery. And also we should see how close to CTO body. If you are so close to CTO body with that collateral, that's also may give you some trouble. Fortunately, we have collateral pathway in 86% of the cases. If you have CTO, this is, I think, good chance. What can we have in terms of, difficulties for crossing collateral? We might have difficulty for collateral cannulation. Sometimes it could be difficult. Sometimes angle is not suitable. Sometimes you may have collateral through stents, or you may have collateral very proximal. So collateral cannulation could be an issue. Sometimes collateral wire crossing is difficult itself because of the tortuosity mostly, and advancing microcatheter is sometimes another issue. So which kind of collateral we have? We might have septal collateral. We could use epicardial, ipsilateral, and also we can use grafts as collateral. I will show you some examples. For example, septal collateral. I'll show you an example here. This is the case we done with Ramiş in Turkey for one of the European meeting. And now we are seeing which collateral is the good one. And we see that this collateral looks to us promising. This one somehow could go to distal. So we target that one. And what we do, firstly, we use workhorse wire to engage these septals. Then we change it to wire to cross collateral. This is BMW, our workhorse. And after we engaging it, we insert our microcatheter. And in this case, we did a tip injection to see more clear to connection. Sometimes it is very useful. Sometimes collaterals are so obvious, but sometimes it's better to do it because you may see lots of branches and you have to see which is the good one. In here, actually, we think that this is the best one. In here, you have to go that way. And of course, we have this as a marker. And now this is the Sion wire. Sion wire, I think the workhorse wire for crossing the collateral at the moment. You see there are some tortuosity. That's why our wire is not that easily goes, because we have some, and then it just jumps, after a couple of tortuosity. We cross it with a small maneuver and it jumps to distal vessel. And we are pushing the microcatheter. It's easy to push it. This is a Corsair catheter, classical one. Now we back to other weave to see better and easily. Now we are distal of the RCA. And of course, we have to insert our microcatheter now. Look how we do it. We torque with the right hand and we push the left hand. This is the technique of how to insert retrograde microcatheter. You can torque this catheter. Also, sometimes if you need it, you can torque even fine cross gently. Now it's easy to approach the distal CTO. And also we can do septal surfing. Septal surfing, that means that if you don't see any nice collateral, you just try with very hydrophilic wire like filter FC or filter XT. You can just push and pull back. If it is find a way, it will go. Otherwise, it will stop and it will give us some ventricular ectropy. This way is not good. We pull it back and we push again. And this time you see it find his way. This is septal surfing. So this is a case we did. We have antegrade fail attention in the same session, and then we like to see the retrograde options for that. Can you see it? Because in my screen we have I have some names on the screen. I hope you will see it. Can you see it?
Yes, of course.
Yes, we do, Omar.
Hello?
Yeah, we do. Yeah, it's good.
Hello?
We can
Very
see
clear.
it.
We can see it, Omar.
Sorry, is there any problem?
No problem at all. You can see it.
BJ?
Yes. Omar, we can see it. No problem.
Hello? Hello?
Hello, we can hear you.
You can hear me now or, okay. Yeah, you can hear me now. Yeah, okay, nice.
Okay.
So you see everything, right?
Yes.
Yeah, we
Sorry.
see your videos and we see you and we see your, we hear you also.
Okay, thank you very much. Yeah. Okay. Anyway, this is the collateral evaluation. We don't see actually nice collateral here. We did LAD dilatation first, and then we see after that we have septal collateral septals here. It may go down, but it's not. We are not that sure. So we try to go that one, and with the wire, the first we wire that septal with the very small wire, the XT, and then we did tip injection. Actually, we don't see that much good collateral here. You see, we don't have that much. But what we can do, we can use invisible septals. And to do that, I think the XT wire is excellent wire because it goes through very small collateral here. You see, XT wire can go through in invisible septals. But the problem is, after that, of course, we think it could happen, but and also it happened, we cannot insert microcatheter because we use very small collateral. This is fine cross, which is very thin microcatheter. It cross even in very tiny septals, but here I couldn't insert it. So what can we do? We can do septal dilatation here. We use 1.2 millitrach balloon here. We did dilatation gently, up to 6 to 8 atmosphere. After septal dilatation, please, I hope you see that we have nice, we push our microcatheter, it easily cross. So we can do septal dilatation if we need it, if we can't insert. In this case, I did also anchoring technique to have better support. Although I have anchoring technique, I couldn't insert it before dilatation of the septum. This is final results. Of course, in this case, because we did septal dilatation and we used invisible septals, we had to check the collateral. This is the result. But after that, and septals are okay. You don't have any perforation, anything. So another issue we might have sometimes, as you see here, we might have collaterals very close to the CTO, actually, like this. This is an issue because our wire will go always down, not to up. We tried, of course, with Antegrade technique here, but we failed it. We tried to do, the first wire is in subintimal space, not in the lumen, I know that. And I sent the second wire. That one also failed to find a lumen. And then we had to go to retrograde approach here because it's very distal. I don't want to do any dissection here because it's already very distal. Easy to go there, of course, because collateral was nice. And then we were able to go up, and we did here, loop. We did loop our wire with long RG wire, and then we did dilatation. But after that, we cannot insert a stent over this wire because this wire comes from the septals, very close to the CTO. So we had to send a wire to the distal. So in here, what we did, Jakir Shan told us about the double lumen catheter. I think this is the perfect position to use double lumen catheter. We insert it over the RG wire. Now we have a lumen here with this double lumen catheter. Very easy to send a wire to the distal of the LAD. You see, this is our workhorse wire and easily went to the distal. So if we have this kind of septal collateral very close to the CTO, I think we had to use this kind of double lumen catheter. This is after stenting, and we save all side branches here. We can use epicardial collateral. I will show you some examples. This is post-CABG patient. We have here CTO of CX. This is post-CABG patient, and also CIRC. This is we can say that it's quite difficult case. We tried to do it antegradely, but we failed. We tried, we failed, and this I see that this collateral goes to distal CIRC. I see that. I will show you that. I did here also. I sent a balloon here to have anchoring. Anyway, we try from Antegrade. In here, you see this is that one that's a branch. It goes after tip injection. It goes. It seems that it's difficult, but you will see that tortuosity is not that much, and we will we went to distal easily, distal to CIRC. In this patient, after having this small perforation antegradely, we decided to go retrograde, and you see that this is SUO balloon. Yes, we have another balloon and wire here to have support. This is SUO wire, very nicely goes distal. In this kind of epicardial collateral, SUO wire is perfect wire. It goes itself, just a little bit pushing. Of course, another important thing in here, insert the microcatheter. After that, the situation is easy and more predictable. Now we are in the distal CIRC, and it's almost in the CTO. And easily we can do reverse cart here. And after reverse cart, we have nice CIRC artery. I think this patient has post-CABG patient, and I think this patient needs this artery, even it's not that big. We can use ipsilateral collateral. This is RCA occlusion. We have nice collateral from this branch to distal, very nice one. You see that? It's a nice one. And it's not that much tortuous. It's very easy for SUO wire. This kind of collateral is good for SUO wire. And we tried, of course, for Antigrade first, but we failed. We don't have that much good collateral from the septals, unfortunately. Yeah, we don't have any nice collateral from septals. In that case, after Antigrade failed, we think that we can use this septal, this ipsilateral collateral. So after having this wire, this branch, we have nice cores. And here, with Corsair and SUO, again, this is a SUO wire, and it's easily bent. You see how easy is that? Sometimes collateral looks difficult, but when you wire it, wire goes easily. And of course, we have to insert microcatheter. To do that, I had to have here, again, anchoring balloon. Yes, because I have only this branch to do something, and I sent a small balloon here. It's 1.2 balloon. It's a small branch, but I had to do it. Otherwise, it's not easy to push my microcatheter to distal. And here, now I am in the distal. What I can tell you here, this is very important slide, because what I have here, I have ipsilateral collateral here, right? I use my retrograde wire through these septals, and it went in the catheter. If I put a stent, over this retrograde wire, then I jailed my own wire in the RCA, which is terrible situation. And in that case, this patient had to go surgery actually, because I will jail my retrograde wire over it. So this is very bad situation. We shouldn't have this. So I remove microcatheter and also retrograde wire here. Then, because after, of course, inserting antigrade wire, this is antigrade wire, I work over antigrade wire, not the retrograde RG wire. If I use it, I'll jail myself in the RCA body, which is a terrible situation. This is another stent, and I have result like this, not bad. This is another issue. We can use, diagonal to circ collateral. We have it. We can use it. We should look carefully. Sometimes it's hidden. In here, I will not show you because my that part is occupied with the videos and names. Anyhow, this through here, you see how easy it goes. This is a Sion. Once you have it, you should focus on it. You should, follow the collateral and wire will go easily. And this is a very difficult case actually, because this is a proximal circ and calcified. This is the one of the most difficult scenario for CTO. So it's good to use here retrograde approach. And also we have bifurcation here. And after we snare it, and then this is the final result. We have all branches here. We can use IVUS guidance for retrograde approach. Sometimes we really need it. This is a LAD CTO. We use retrograde approach here after antigrade failing. Sion wire cross the septals. You see how close it is. Sometimes from RCA to LAD, it's very difficult. We should know that. We should spend some time. What do you think about that? Wire looks in left main, right? But somehow we never insert this wire into the guiding catheter. So it tells us something. So we think that we might be in the subintima, right? Because why we couldn't insert our microcatheter to our wire into the antegrade catheter, guiding catheter. So what we see here, obviously it's subintima, right? So if we use this wire, if we snare it, if we do something, we might lose circ here because we are in subintima. And I will show it nicely. And we tried redirection of the wire, and you see now it's in the lumen. So we can work over this wire, and the catheter is the wire is in the catheter, and this is the after 2 slides. So last slides, I'll talk about using graft collateral. I mean graft as a collateral. This is very nice, actually. People use it a lot now. So this is RCA occlusion. We have very ugly, very diseased RCA, right? It's almost subtotal occlusion. So it's nice RCA, but we have subtotal occluded. This is 8 years of the graft. So what can we use? We can use easily this graft. Yes, we have left system. LAD lemma is okay, but we don't have any collateral from this the left. It's obvious because we have nice flow from the diseased graft. What we can send, we can send easily wire from this graft. It will go easily, and then of course we can do retrograde approach. This is after put I think 3 stents, and we have very nice distal feeling, and fortunately graft is occluded itself because we have nice flow. This is the last case. Also we can use occluded graft as retrograde path. We might have this scenario more often than diseased graft. This is RCA occlusion. This is an interesting case because we have nice collateral from Lima to Lima LAD and LAD to retrograde, right? We have nice collateral, very epicardial, nice one. But this is only collateral we have, and we have antegrade flow like this. You see, if we try to use this collateral, we might be in a big problem because there could be ischemia and everything because we have only this artery supply for whole heart. Anyhow, in this case, this is the occluded part. This is the occluded part. This is the graft. We have occluded graft here. This is occluded right graft. We see that. We tried antigrade. In this case, actually, from the beginning, we aimed to do ADR in these patients. But unfortunately, we had a big dissection at the distal, big hematoma, and we failed to do, recross it. So for us, Antegrade game is over. We think that what we should do, we have nice collateral from LAD to RCA, but I don't think it's a good idea, because if we try to do this, we definitely might have ischemia and maybe occlusion or cardiac arrest. So then you see we have nice occluded artery, it's down takeoff. We did just send a pilot 200 and macro catheter. Very easy to go to distal. It takes, you see that it takes a couple of seconds to go down. And then we went down. After that, of course, and of course, we did a small ballooning here to insert macro catheter and other things with 2O balloon. And then here, we have to go that way rather than down. In this case, again, we use double lumen catheter, which is twin pass in this case. We send a Fielder FC, and Fielder FC went nicely to the distal of the RCA. So I think we should think to use, especially for post-CABG patient, we should think to use occluded graft in those cases, if you don't have nice collateral from the other artery. This is final result after implantation 2 stents. The distal target is not that good, but not that bad, and I believe that it will improve by time. So I think this is my last slide. I thank you very much for your attention. I think I spent my time a little bit. I apologize for that. I thank you very much for your attention.
Thank you, Dr. Omar Goktetin. A very good talk, very good cases, very complex, very good cases. And you've shown various ways we can use also the graft in bypass surgery patient, even occluded graft. Rarely I have heard this occluded graft being used for retrograde cannulation. It's really great cases, brilliant cases. And now this ball is rolling for the question, answer, and discussion. And the important question that first I would like to ask Jay, that how do you control the efficiency? Is there any strategy to control efficiency of time, contrast, and the radiation?
Well, I think that the main thing is to be aware of all of those things. So first of all, we use specialized fluoro package in our room, very low magnification, 25 centimeters, low frame rate, 7.5 frames per second, very little acquisition. Almost everything is done under fluoro saves to minimize radiation dose. We try to use minimum contrast. We use ultrasound guidance for most of our stenting and optimization. And as far as the actual procedure goes, we are really proponents of Antigrade first. In our experience, within 20, 25 minutes, if it's going to work, it will have worked. And if it has failed, now you're ready for the advanced crossing strategies, whether it be retrograde or ADR. So you just have to have a plan, as other speakers have pointed out. You have to have a plan up front, but be cognizant of all of these side issues, the ACT, the radiation, the contrast that you delivered, the patient comfort, the staff comfort. So that being said, we're a teaching institution. Our procedures are probably not as efficient as they could be, as they were when I did these on my own in a community hospital, but it's a responsibility that we take seriously to make sure that we teach our fellows how to do this stuff.
Yeah, very good. And when you want to select a wire or a microcatheter, for that matter, for any given CTO case, what do you like to see, and how do you decide? As we discussed that for the proximal cap escalation with the wire, we usually prefer a low tip load wire with the polymer jacketed wires. So any other way of thinking?
I think that the thing to understand is that the wire and the response of the wire fluoroscopically are telling you something, and you have to look at that. The way the wire behaves when you probe a lesion can make a 20, 25, 30 millimeter lesion actually an 8 millimeter lesion. If you pay attention to what the fluoro is showing you, if you pay attention to what the wire is doing, rather than being quick and aggressive to try to be efficient, if you just pause and take a look at some of these cues, and I tried to point that out in the talk, there's some things that the wire is telling you that if you listen, it sounds a little hokey, but if you listen and observe what the wire is doing, you can often make a very, very complicated case a very straightforward case. And if you can keep it antegrade, we know that we can reduce complication rates, which is ultimately what this is about. Not only success, but to do it with low complication.
Yeah, so tactile and the way wire tip behaves when you try to escalate into the proximal cap. Based on that, you keep changing your wire sequence of wires.
It's a very simple matrix. It's soft wire, intermediate wire, puncture wire. That's it. And then
Absolutely.
You pick 2 or 3. There's
Yeah,
nothing
absolutely.
to have 20 wires.
Proximal cap entry with the soft wire, middle CTO entry with the drilling wire, one of those Gaia or any other judo wire, and then the penetration of the distal cap with the tougher wire like Conquest Pro or for Hornet. Depends on what strategy you want to use.
It honestly depends on how the wire is behaving.
Yeah.
Start with that soft wire, then you can decide what you need next.
Absolutely, absolutely. Dr. Omar, I have a question for you. When you use a microcatheter, particularly in the collateral, what tips and tricks do you recommend for use of and forward movement, backward movement, when to use, how to save on dye, contrast, all those things a little bit in detail?
Yes. So when you use microcatheter, you can use either Corsair Pro, and you can use, in my practice, I use also Fancross a lot for retrograde approach. You can use Turnpack LP.
Does it depend on the size of the collateral? The microcatheter use, does it depend on size of the collateral also?
I think, yes, I think that's important. If you have really small collateral, I prefer to use, in that case, Fancross. You know, for septals, even if it is small, you can use Corsair, because obviously Corsair is a kind of dilation catheter as well. You can use Turnpack LP in that septals. For epicardial, you can use again Fancross and other. For Antegrade, you might need more sportive catheter for Antegrade, but Retrograde, it's nice to use low dimension catheter.
Particularly if the collateral is very tortuous, then which wire and which microcatheter?
Yes, in my practice, because there are several approach, obviously. Everyone use their own technique, but I can tell you my own approach. If I have a very tortuous collateral, I use SUO if I have it. SUO wire is excellent wire. And if I have very tortuous one, if I have epicardial, I like to use Fancross much more than Corsair or LP catheter, because in Corsair sometimes in epicardial it may jump and it may perforate the epicardial. That's, I think, issue because they have a big noise. If you have so much tortuous, that noise, the nose may prevent you. So if I have tortuous epicardial collateral, I prefer Fancross.
Fancross. And then with Corsair, how about the movement of the microcatheter? Any trick in the forward movement of the microcatheter, particularly Corsair or Fancross?
If you use Corsair, obviously you can torque it either
anti-clockwise.
Yeah. Both of them is okay, and also you need to push with the left hand. Yeah, this is the most key of the inserting microcatheter, torquing and pushing.
Okay. And when you had a edema, vascular edema in one of the cases, and you have dye staining showing that there is some vascular edema there, and then you continued with the procedure and successfully completed that procedure. How did you change your approach in selecting a different vessel?
You mean the last case with
The last case where you
Yes.
had a dye staining.
Yes. So in that case, I like to use ADR from the beginning, but fortunately I failed and I had big hematoma, and I think that my antigrade chance is very small. In that case, I saw that occluded saphan graft. I know that it could be a good target for me. I would never use that LAD to RCA collateral with epicardial one. Since I know that I can cross that occluded graft, I just go directly occluded graft. Vijay.
When you do a retrograde and you cross through the collateral and from true lumen to true lumen in the recipient artery and reach up to the guiding of the recipient artery, and then you're unable to put it into the guiding, the collateral. So you need to externalize. What techniques do you use to externalize?
So you're asking if I cannot insert my wire into the guiding or microcatheter?
No, into the guiding. You already crossed the collateral and the distal vessel, and now you want to push your wire into guiding.
Yes.
To externalize it, but you're unable to do so. Then you use some snare to externalize it.
Right. So in that case, if I am in the proximal vessel, but I am not in the guiding catheter, it is very difficult. What I do, I insert my CTO wire very proximal, very distal aorta. Yes, and I have a nice support, and I try to push my macrocatheter over that wire into the aorta. If I did it, it's nice, because then I will change my CTO wire with the RG wire, and I will snare that RG wire. Mostly, we don't like to snare CTO wire. Yes, it's important. Yeah, so it's better to actually it's not better, but we have to snare RG wire rather than CTO wire, right? Because snaring of the the CTO wire could be very problematic. If you do it, you should do it very carefully. You should do it very carefully. Better avoid it, but sometimes you might have to do it, but you should in very clever way. You have to snare at the very distal part, and after inserting microcatheter into aorta, you should just release it. Yeah. So that's you might have a problem with that.
Okay. Arun?
It is a rendezvous technique, and if you can't do the rendezvous technique, I think snaring RG3 is recommended. Otherwise, it can shear off some of the septals and cause more damage. And Omer, some of the questions that you have for epicardial collaterals, do you use Caravel from Dr. V.T. Shah?
Mm-hmm. Yes, Caravel. Yes, yeah, we use Caravel as well. Yes, I forget to mention actually in my lab. Yes, we use Caravel, and it's really nice microcatheter as well. Yeah, thank you for mentioning.
Arun.
Yep.
Arun. When you do a stingray and stingray balloon is flat and it has two wings and three exits.
Right.
So how do you position your balloon in such a way that it faces towards the true lumen and exit, so that you can exit the wire into the true lumen? Once one case you showed that you put a stiffer wire as a stick and then you replace it with the softer wire for the entry. But I'm asking about the balloon position. How do you align the two portions of the balloon so that the exit points are facing towards the lumen?
So by definition, right, the whole idea of the stingray balloon, I mean, I don't know if you can see my hand, but I mean, it's shaped like a stingray balloon. So the proximal and the mid hole, are 180 degrees apart. So the balloon orientates itself the way it does. So by definition, right, one hole will be towards the way it is. say you have the whole thing. Okay, hold on. Let me just try to show it like this. Can you guys see it? Okay.
Yeah, we can see
If
it.
this is the lumen and the balloon is this way, one hole will be towards the lumen and the other hole will be towards the adventitia. That's the whole idea of using a Stingray balloon. You don't control how it, I mean, you could pull it, move it, etc. So don't get dogmatic on where you want to re-enter. So sometimes you might have to, especially in a very calcific vessel, and if you have created a big knuckle, the balloon might just spiral around just because the wire has spiraled around. But typically, you can't control how the balloon orientates. And which hole you decide really depends, I mean, depends on how the balloon is oriented. And you want to move the II around so that you can get the right hole. So it is what it is. And, you just got to position it where it is and then get the right position by moving your II around, not the balloon as your first choice.
Yeah. And when you have an edema, suppose you're doing you develop a edema in the vessel, then what is your strategy if the edema is significant?
And I mean, I think Omar's case was fantastic, to actually discuss the whole thing. He went into an option of ADR. And the key point I want to emphasize is that any of these options can fail, number one. So you always have to have, kind of think on the fly and say, okay, what am I going to do if option A or B doesn't work? Like what's the next option, right? So I think that was really good thinking. Now, the second thing is it's about preventive stuff. So form the smallest knuckle that you need to do. I think the first and the most important thing is if you're going to knuckle, form the smallest knuckle, because the bigger knuckle is going to form a bigger hematoma. So, and different wires knuckle differently, right? So an XT forms a tighter knuckle than a Pilot 200. I mean, Mongo is dedicated to form small, tight knuckles. And so again, use the smallest thing to get the job done. There are times where you end up wiring in your subintimal, in which case, if you just take the Stingray right over it, it's a much more contained space. So number one is prophylaxis. Make sure you don't inadvertently inject Antigrade, because that is a big no-no, right? So take off the syringe like I'd shown. And of course, if you have access to a trap liner, etc., once again, control the inflow. You can use guide extension catheters and aspirate through that. You can put in a microcatheter adjacent, aspirate through that. You typically these days, I almost always aspirate through the back end of the Stingray balloon catheter in order to reduce hematoma. So it's all about managing hematoma, reducing inflow. And and sometimes despite our best efforts, it doesn't work. And you have to have an option B or C.
Yeah. Do you abandon if the hematoma is big one, then you abandon or proceed with the another approach if the feasibility is there?
Again, it really depends on your comfort level. Sometimes, it's a no-go, but there are times where you have a hematoma and you lose visualization, but you can still do a blind, double stick and swap. So again, it depends. In India, again, one factor that we always think about is the cost of the procedure. So the Stingray balloon comes at a different cost. So if I have a reasonable retrograde option, I'm going to take it. If I think my chance of ADR is not that high. But again, typically when money is no object, I'm already there. So the worst I can do is fail. And if I fail in ADR, I'm already set up for reverse card. So to me, it's not a big deal if the patient can afford it. But if you're thinking, okay, I got to do it in the most efficient way, also, typically before I came to India, the factors are radiation, contrast, avoiding complications, and time, cath lab, etc. Now we always also have to think about how much cash am I going to burn.
The India cost consideration becomes very prime if you want to do a CTO volume. Some patients, of course, they can afford any kind of hardware on any cost, but some are, majority are unable to afford very high cost PCI. And there are several questions and chats which are already answered, but how often do you go for a straw in presence of a Stingray and crossbars? How often do you go for a straw or star or for that matter last?
So, just to answer this, I routinely straw, every time. So once the balloon is there, while I'm waiting to position it, I at least aspirate through the Stingray catheter, just because, while I'm waiting, you're still having inflow. So why not avoid it? So I routinely do that, number one. Number two, let us say it doesn't work. Yeah, I mean, there are a portion of cases where you end up just starring it, bringing them back in about 6 weeks to readdress the whole issue. Because I mean, the worst thing you can do is persist and end up in a needless complication. I think the biggest lesson, and I think Jay kind of hit the nail on the head earlier, knowing when to stop and avoiding complications is probably even more important than your success rate. I mean, too often we get hung up on, hey, what is your success rate? How likely are you to succeed? I mean, honestly, I think all CTO operators know we all fail. And the key is to know when to stop and when to avoid. I mean, if you can do anything to avoid a complication, you should.
What are your stop criterias?
Okay, that's another question for me. All right. Obviously, if this is I mean, I think in today's, with the machines and the radiation settings, we almost don't even go close to 5 gray. I mean, I have a Azurion 7C12. I mean, 2 gray is way, I mean, I don't even go there. Contrast, radiation. If you have a complication and you really want to stop, yes, there are some complications where you can persist. So you need to know which is the complication there where you need to stop, which is the complication where you need to
Proceed.
where you can proceed. And again, there are some cases where you're kind of running out of options. I mean, star, and you might just want to say, am I going to take this crazy, the case where Omer showed, right? If, let us say he couldn't open the graft, right? For whatever reason, instead of taking that Lima, LAD, and that epicardial, you might want to consider just starring that patient. You already have a hematoma, just star into the PD, bring them back a couple of weeks later and reattempt. I think that would be a prudent time to say, hey, I'm not going to stent you now, but it's okay to stop.
Jay, how do you approach the reattempt? Because that becomes sometimes easy, sometimes it's difficult.
Yeah. So that depends. So, we're a large referral center, so we get a lot of outside failures, lots of failures. So we absolutely need to have the outside films, have a chance to study them to understand what's going on, have a frank discussion with the patient about what the options are. But that's issue number one. So if there was a complication with that case, we would want to wait at least 6 weeks before we try to reattempt, because we don't want to end up in the same dissection planes that were already created. In our own failures, typically we do star in all of our failures and balloon dilate the proximal segment. We don't usually take an injection. We make sure that the patient's stable. There's no indication of tamponade, and just take them off the table. And we ask them all to come back in 6 to 8 weeks, and are very pleasantly surprised at how many of these vessels are open and how easy it is to take care of the problem. We actually had to convince some patients to come back because they feel better after these investment star procedures. But so the short answer is 6 to 8 weeks. But with all that the information from the outside attempt, we have to have all that information.
And which patient do you think, can you guess it? Which patient will be easier for reattempt?
It also depends on what the options were and
are there any criteria?
I think that anybody who had a star, we should always bring back. I think that those are the ones that are the most pleasant to bring back, because it almost always is just a nice antegrade procedure and the patient feels great. Patients who had an expert operator go through the entire algorithm and still failed, those are the ones that you lose sleep at night, that, oh my gosh, what am I going to do that this other operator didn't already try? But sometimes just the investment of the previous operator softening up the plaque just changes the behavior of the wires. So I go back to the behavior of the wires. You go in and the wire will tell you what's possible very quickly. And just from the prior attempt, the wire may behave very differently the second time around.
Yeah,
so I never
can you
tell people no.
a little bit explain about this wire thing that you are, of course, it is a lot of personal tactile thing, but apart from tactile.
So number one, you start with a soft polymer jacketed wire. There is no tactile feedback, zero with a soft polymer jacketed wire. It's purely visual. The wire is going to go straight with no deflection, or the wire is immediately going to deflect like this. The minute the wire deflects like this, I tell the fellow, you either change this wire or pull back and try again. If the wire goes straight, then you're okay. If the wire keeps doing this, we're done. Let's move on. The next step is the deflection rotation. So you take an intermediate wire, guy a second, it will deflect. As soon as it deflects, I tell the fellow to stop and rotate. As soon as you rotate, it actually tears the tissue. Then it will advance, and you keep deflecting, rotating to work your way down. If that doesn't work, then we're left with Antegrade will not work, and we are going to set up for ADR. We take Mongo, push the Mongo in, make it knuckle, push the Mongo down. If the Mongo re-enters with a star, perfect. If the Mongo stays subintimal, we do Stingray.
Good.
If that
Excellent.
fails, then we go retrograde.
Excellent.
Great.
Ramesh, about saving the contrast, what techniques, I mean, this is very important for everybody, you know, saving the contrast during the CTO. What techniques do you use?
I mean, we use Osprey. There's a system called a divert or divert system where the excess injection does not go into the patient's body, and it is diverted to a bag or a collection outside. But that said, actually putting a guide liner and injecting, I think, will definitely save a lot of contrast. And as Jay said just now, you know, you don't keep injecting, and I think Arun also showed the case, at least said that you will increase the chance of hematomas. You disconnect the syringe, you go by both the tactile as well as or fluoroscopic deflection of the wires, and then don't inject to see where you are all the time, you know. So you know, I think it's just experience. In the beginning, I also injected a lot more contrast. Now we save contrast.
Okay. And in case, suppose, do you use Stingray and in your practice crossbows?
Yeah, we do use it, and not as often as probably Arun.
But any other hardware you use to penetrate the proximal cap in case the routine wires are not working, like
No,
Tornus or any other?
No, I don't use Tornus, and usually the microcatheters or whatever. I don't know. I mean, in my opinion, I think microcatheters are so expensive. I mean, so many, and you know, you can't keep changing. We get used to one or two of them, and you can try other things. And Turnpike LP works for us. Caravel works for us quite well. So we use mostly that, and Fine Cross especially. We keep that also on the shelf. So I don't think there's any particular way of doing it. I think I agree. Jay easily mentioned very well. Short polymer jacketed wire, then Gaia second or Gaia third, and then upsize to Mongo and ADR.
Right, absolutely. Any one of you use MDCT in your lab as a co-registration for cases, and how does it help? Jay?
Yeah, we use it.
Okay, Jay, Omar, both of you, please answer this.
We use it, honestly, what we found it to be most useful for is understanding the path of the artery even before we get in. The code registration is not as useful as pre-planning the case beforehand. We actually recently published a case where we 3D printed the CT angio of an anomalous RCA that came off the left cusp, and then practiced beforehand shaping guide catheters to understand how best to engage the coronary artery. So I find it to be much more useful for pre-planning rather than in the case. We do have it in the case, but quite often we're not even looking at it, to be honest with you.
Okay.
I fully agree with Jake, Vijay. Yeah, I think pre-planning is very important. Very useful. During the procedure, we use it. If we have ambiguous cap, for example, LAD ostium, if we don't see LAD ostium or RCA ostium, in that case we use it. But it's not that much helpful maybe to use for co-registration purpose. I agree with Jake, 100%.
Okay, most of the time when it comes to imaging in the CTO, intravascular imaging, we try and use IBUS most of the time during the case. But sometimes OCT can be used in a particular situation.
I think OCT can be used to optimize your stent at the end, but the problem with this is we're going in and out of subintimal spaces most of the time. And so that's where you don't want to be pressurizing a hematoma. So I don't know that OCT is a terribly practical tool up front.
For any CTO, for that matter.
No.
Okay. That's good. I think we have this, thinking that imaging is now become a very key for any PCI, for that matter, Leftman PCI or CTO PCI. And you showed some cases where IVUS imaging was very helpful in your case, even when Omar showed that left when he was subintimal, how IVUS has helped him to understand that it's lying subintimal, so he could change the approach and did the case successfully, completed the case successfully. So these are very important understanding that we have a CTO. I mean, full CTO, if you do retrograde, antigrade, you do ADR with Stingray and RDR with balloon or whatever technology needs to be wire to wire, true lumen to true lumen. Various strategies are there. And fluoro time, how much do you allow the fluoro time in your lab? I would like to know from Omar also this fluoro time, because this fluoro time is something which is now catching up in the CTO program very seriously, that we need to cut down the fluoro time. We employ all those techniques, reducing frame rate, all those things. All that is done, but yet particular gray number that if it is exceeding this number, you don't want to continue the case.
Mostly we look not for duration. We mostly look for gray, and our limit also 5 gray. But I agree with I mean, in my practice, maybe we have more experience by time. Most of the time, our cases, finish. To be honest with you, less than 1 hour. Most of the time. So fluoro time is that issue for us.
Okay. And when do you use Protect PCI in CTO? Any time when you use Protect PCI? The support, hemodynamic support during CTO?
Personally, we don't use it, no.
No. Jay?
Yeah, we do have to use that on occasion. We have patients that are referred in cardiogenic shock who've lost a vein graft, who are unstable, that need revascularized. And rather than open the vein, we typically will open the CTO. That often we'll do with mechanical circulatory support. Sometimes we have to occupy the last remaining bypass graft that a patient has, and that's not very well tolerated. Patients get very, very ischemic. And so we use mechanical circulatory support to ride the patient out. We've had patients who, after successful CTO, had very poor outflow because their end diastolic pressure was too high. So we put in mechanical circulatory support at the end of the case to acutely lower end diastolic pressure and improve coronary flow. So we have multiple issues that have come up that have required it. Okay.
I mean, I was asking prophylactically. I mean, in patients who are presenting with cardiogenic shock, no problem, we can use. Okay. I'm asking prophylactically.
Yeah, so we always measure an EDP. We look at their pressure at the start of the case. If their systolic is 120 and their EDP is 12, then obviously we're not going to start with prophylactic mechanical circulatory support. So it's a case-by-case scenario.
Do you do that in your practice, mechanical support? Okay. Arun, any about this question?
Well, I mean, I would completely agree with Jay. I mean, and in general, the other thing is like, the times when there are lots of times when I wished I had an Impella or something to help me out, but in a lot of places that I've gone to for proctoring, I don't have it. You get especially worried if you have, let's say, impaired EF, LVDP is high, you're kind of going through, and if you're going to have to go retrograde and you're going to cause a lot of ischemia. So there are times when I'm actually backed off because the patient doesn't like it, and you can tell. I mean, unfortunately, if like, for example, in some countries, they just didn't have Impella, like when I was proctoring, and you don't have an option. So if they don't like it and the patient's telling you the hemodynamics are getting worse, you got to just back off and not take that conduit. So yeah, I mean, I think you got to be super careful, increase LVDP, low EF, retrograde through, and you're causing a lot of ischemia. So whatever the anatomy is, that's going to lead to that. So you just got to be cognizant of what you're doing to the patient and how they're responding.
Yeah.
Which IVUS, Jay, do you use?
Yeah, I have to go to.
Guys,
yeah, one thing is that I mean,
Ramesh, are you trying to go early a little?
Yeah, I'm leaving right now. I have to leave.
Okay.
I'm on call. So Impella or mechanical circulatory support in CTO, I think it should not be the go-to. It should not be the first option. If the guy is requiring for an elective, I'm talking about, as what Jay said, for cardiogenic shock, obviously cardiogenic shock is separate. but do not fall into the category that every CTO needs an impeller. That should not be. We should not be the ones who are. We are not salesmen for any company.
Only rarely.
Very rarely. I have not had to use impeller electively for a CTO. I mean, if that patient is so ischemic, there are other reasons that it's not just a CTO alone. So there are probably other lesions which are
unless it's a proximal LAD CTO and a poor LV due to that. Sometimes you require to use.
So, but I mean, I'm actually, okay, this is a little bit of a controversial statement, but I'm just going to say this, in the last, how many ever years since I left the US, I mean, I've done a lot of CTOs. I mean, in fact, but I'm telling you, but like, and I have to agree with Ramesh, like, we didn't have impeller in any of those countries in the APAC region. And for the most part, I mean, outside of one or two where I had to back off, we were able to do it without it. So I would actually kind of agree with Ramesh there. There are times when, yes, I would have loved to have it, but it's probably a very reasonable statement to make. I mean, especially here, it's about, I think it's about 15 lakhs, right? Like in India?
Yeah, 17, 18 lakhs.
Okay, well, a lot of very few people can really afford it,
Absolutely. No, I'm not asking from that point. There was a question asked on YouTube by some participant about this, the support being used prophylactically in proximal LAD CTO where EF is low.
And the other time is
if the LVDP is high, EF is low. These are the situation where one would like to use.
And one other strategy is to stage it, right? I mean, if you have a critical lesion there, hopefully appropriate revascularization, if it improves the EF, decreases LVDP, etc., and then tackle the CTO later, stage it. Don't try to do everything in one go.
Absolutely. I agree with that. Staging is very important in multivessel angioplasty. And I think any more questions? Anybody would like to add something? Omar, Jay?
No, thank you very much for invitation.
Thank you very much for your participation.
Ramesh and Jay, great talking to you guys.
We all enjoyed thoroughly and very good cases. Lots of cases all of you have shown, and very interesting, very complex cases, very successfully done. Various type of techniques are used. All virtually everything was covered throughout by case examples, which is very, very good, for learning purpose. Apart from that, we had a good discussion, and thank you very much to all of you for this excellent presentation and discussion. We all, I think, participants have learned a lot, and even I have learned a lot through the process. It's a very good discussion, a lot of cases. Thank you very much. I applause for all of you and participants.
Thanks for putting this together.
Thank you very much. Thank you a lot. Thanks a lot.
Thanks, guys.
Bye-bye.
Bye-bye.
Nomar, Jay, and Arun, thank you very much. And you could continue, but unfortunately, I had to leave. But,
no.
I think we should probably call, call it to an end. If I can speak on behalf of all the speakers, like, feel free to reach out to any of us if you have questions. I put my number on the chat group. I'm sure most of us are more than happy to take questions offline. And if ever in trouble, feel free to reach out.
Absolutely.
Yeah.
Thank you very much.
Thank you. Bye-bye.
Thank you very much.
Bye.
It's very interesting.